My name is Ganesh Radhakrishna. I'm a consultant clinical oncologist based in the Christie Hospital in Manchester. I am currently the oncology lead for the National Pancreatic Cancer Audit Program. Fundamentally, an audit is a comparison of how our performance is against some benchmarked data, or what we call metrics. So it looks at data that is already available within the UK healthcare systems, in this case, NHS England and Wales databases. It will draw on data of everything from a patient's admission, how long a patient stayed in hospital, when they received their diagnosis. We'll also be tapping into a variety of other databases, such as databases looking at the treatments that patients may have received, when, where, and what treatment that would be. So, for instance, in pancreatic cancer, this would be looking at what we call a systemic anti-cancer therapy database and a radiotherapy database. So these two separate databases collate and collect data on all the patients who've received chemotherapy and or radiotherapy during the course of their treatment. What we will be able to then glean is we could look at anything from how many patients got treatment in a particular hospital, a particular region, or all of England. And we can then compare that to, say, the performance of, for instance, other cancers in the UK. So bowel cancer, how many patients who have bowel cancer who have been diagnosed receive treatment, that proportion, and how many patients with pancreatic cancer have treatment. And that's quite an important metric, quite an important amount of detail, because it gives us an idea of how we are delivering care to patients. We can do the same with radiotherapy, we can do the same with surgery, we can do the same in terms of looking at how patients were admitted. All of this is really, really important data because it gives us an idea of what we call real world data. So this is not information that may have come from, say, a clinical trial where patients are actively recruited. This is real life. This is what's happening. It gives us a lot of detail in terms of outcome, because we can then also look at the complications. So how many patients, for instance, had a severe complication, say, after surgery. In its crudest form, it can look at things like when the cancer may have progressed after chemotherapy, or even how long the patient's survival may be over the course of a treatment. And these are also very important pieces of information, because it can then be compared to things like clinical trial, or crucially international data, to see if our outcomes are better, worse, or much in line with what we would expect things to be. We already have some of that data available, and it might be interesting to know that there is significant variation in how patients across the country, even if we're just looking at England or just looking at Wales, even within the regions, of how patients may be accessing treatment, how long it takes them to get a diagnosis and get onto treatment. That variation is quite critical, because it does mean that there may be certain areas where there is excellent practice, and we want to learn from those regions and make sure we can bring the rest of the country up. But equally, there might be outliers where outcomes may be not so good, and we need to recognize, identify it, and identify ways to ensure that that is corrected in a way. And one of the things would be looking at access to treatments, and access to treatments in a timely fashion. It's probably not the best way to start an interview with the bad news, but it may help to sort of paint the picture of the current context. Pancreatic cancer is one of the least survivable cancers, and we know that that data exists in the United Kingdom. It is the one with the worst outcome of all of the 6 least survivable cancers. Data that has looked at the trajectory of pancreatic cancer compared to other cancers between the 70s to the early 2010, 2013 period has shown that there has been virtually no improvement in the survival of this cancer. It has, unfortunately, the worst outcome. However, that data is 10 years old, and things have changed in that period of time. And so what we hope to start to see and glean is whether those changes based on newer treatments that have come online, newer approaches, newer technology that means that we're able to diagnose and hopefully treat patients sooner, is that having an impact? And if that impact is there, is it actually improving outcomes? Another not so good statistic to highlight is at this point in time, at the point of diagnosis, based on cancer statistics websites and cancer registry data within the United Kingdom, only 30% of patients, that's less than 1 in 3 patients who are diagnosed with pancreatic cancer, will receive any form of anti-cancer therapy, be that surgery, radiotherapy, and chemotherapy. And so it may not be a huge shock that the outcomes are so poor. It is a very difficult cancer to diagnose and treat. And so there may be delays in diagnosis, and it might be a pathway issue. We hope the audit will be able to pick that up and also pick up variations across the country so that we can identify areas where we can learn good practice and identify areas that might need a little bit of support or change to try and bring their standards up. It might be that it is a demographic issue. We know that pancreatic cancer outcomes tend to be worse in more deprived population. And so once again, it is trying to target resource and being able to identify the problem and map it out. So I think that what we hope to try and do with what we already are seeing and sensing at this level is to look at this with more granularity, with more detail, and really drill down and scrutinize the data to identify what those particular issues are. But there's a lot to be optimistic about because a lot is changing. And what we need to try and do now is sort of identify the big picture and then slowly start to focus and drill down into the areas where, as I said, we may need to invest, we may need to resource, and crucially, we may or should start to focus our efforts into research and innovation to improve outcomes.